Welcome to my YouTube channel. Today we are going to talk about pathophysiology of preeclampsia. Kindly make sure you subscribe. It will cost you absolutely nothing. And we are going to begin with the pathophysiology. And first we will deal with the risk factors. And the risk factors, we have divided them into maternal, and we also have divided them into fetal. So in terms of maternal, we have late maternal age. So if already you are greater than 35 years old and beyond, primigravida, that is the first gravid. We also have new paternity or new partner. So if this is new partner compared to the other previous pregnancy, genetic factor or family history. So if your mother had an history of preeclampsia, or you have had a previous pregnancy which had preeclampsia, and this is just what I was saying, that's previous history of preeclampsia. And in the genetic in terms of fetal, we have multiple gestation. So next we're going to talk about etiology. In terms of etiology, it is unknown and it is considered to be multifactorial, meaning a lot of factors are involved in terms of causing the etiology. In terms of multifactorial, you have genetic, we have immunologic, we have hormonal, and we have environmental factors. So we're going to begin with the pathophysiology, and before we begin the pathophysiology, we're going to do the physiology before we do the patho, the bad part. So the physiology, we have invasion of the spiral artery by the trophoblastic tissue, and then that will result to deserialization of the myometrial and decidual segment of the spiral artery, which will later result in the replacement of the muscular and elastic layers of the spiral artery, followed by fibrinoid and fibrous tissue, which now will result to large, tortuous, and low-resistant channels that will extend through the myometrium. So in terms, what I'm just talking in terms of the physiology, this is the normal pregnancy, and these are the spiral tissues. So the spiral arteries will invade the decidual, that is the decidua, and will have large, tortuous, and low-resistant channels. This now will enable blood flow to flow from the mother to the child. And as you can observe, these are large and tortuous, meaning they are low resistance. In comparison to preeclampsia, which there is abnormal decidualization or there is abnormal invasion of the trophoblastic cells, which will result to narrow, if you can say these are narrow channels, which are high resistance, therefore causing preeclampsia. So we now go to the abnormal part, where we have inadequate trophoblastic invasion, as I previously mentioned. And with this, you are going to have, so where we had deserialization of the myometrial and decidual segment of the spiral artery, now we will have it just limited to the decidual segments of the vessels. And later we will have high resistant uteroplacental circulation with subsequent impairment of the uteroplacental perfusion. And this now will cause preeclampsia, and in later we'll have formation of radicals, and then we'll have later inflammation and vasoconstriction in the mother. So this is another image just showing us what we have just explained, and this is the normal tissue, where we have invasion of the trophoblastic cells into the decidual of the mother, into the decidual, as you can observe here. And as a result, we are going to have large tortuous tunnels that are low resistance. And in comparison to preeclampsia, where we have abnormal invasion of the trophoblastic cells, and you are going to have reduced blood flow or small channel, narrow channel, which are high resistance. And these channels are going to cause reduced blood flow into the mother. And later, now you can have things like apoptosis, oxidative stress, and later you have mitochondrial dysfunction. And this stress in the syncytiotrophoblasts are going to cause cytokines to be released, which will enter the bloodstream, and after entering the bloodstream will cause inflammation and vasoconstriction. So just what we have said, that is high resistance uteroplastic circulation with subsequent impairment of the uteroplacental perfusion, as we left. And then you're going to have placental ischemia. After we have had placental ischemia, we are going to have oxidative stress and production of toxin, which will now enter the circulation. Later, you're going to have widespread inflammation because of this oxidative stress and production of toxin, which have now entered the circulation. You're going to have now widespread inflammation into the mother's side, and endothelial injury and dysfunction leading to altered permeability and vasoconstriction. When you have altered permeability and vasoconstriction, what will happen? We'll have extravasation of fluid from the intracellular to extracellular, and inappropriate activation of the coagulation pathway. In addition to that, you also have widespread vasoconstriction, as we said, and this is going to cause systemic hypertension and ischemic in the vascular vessel, and this is just what we call preeclampsia. In addition to that, we see that we are going to have altered permeability, and this will result to extravasation of the fluid from the intracellular to extracellular. And because we said we are going to have inappropriate coagulation system, you are prone to have intravascular coagulation with progressive consumption of the coagulopathy. So widespread constriction is going to cause systemic hypertension and ischemic in various vascular bed, and this will result to the first thing that we're going to talk about is the head. So neurological impairment, this will now cause the systemic hypertension and ischemic in the various vascular bed in the head is going to cause intracranial pressure. Now, when we have intracranial pressure, to represent with the following: visual field disturbances, new onset headache, hyperreflexia and conus, and seizures, which are now going to present as eclampsia, which is kind of a complication of preeclampsia. In liver, we are going to have liver impairment, and what will cause this because blood will accumulate in the venous system of the liver, and this will cause liver enlargement. In addition to that, if liver enlargement occurs, you're going to have elevated liver enzymes and low platelets and hemolysis. In addition to that, this will present as epigastric pain because of the enlargement, and because you said we are going to have elevated liver enzymes, you have elevated ALT and AST levels. In addition to that, this elevated liver enzymes and low platelet and hemolysis is a complication called HELP syndrome, which I've talked about in one of the videos that I've made. So in terms of renal impairment, you are going to have glomerular arterial vasoconstriction. We said you are going to have widespread vasoconstriction or systemic hypertension and vasoconstriction. So in terms of impairment, we also, in addition to the alveolar vasoconstriction, we're also going to have altered glomerular capillary permeability, and this will cause us to have proteinuria. And meaning, if we will have proteinuria, then we are going to have proteins in the urine. So we go back where we said glomerular arterial vasoconstriction. When you have a glomerular arterial vasoconstriction, then you are going to have decreased glomerular filtration rate. And in terms of that, then we will have, if we are not going to filter, then we will accumulate toxins that include urea, creatinine, and urate. So when we are doing one of our laboratory tests, these three of them will be elevated in our bloodstream. So, and this, in addition to that, will also result into acute kidney injury, which is one of the complications of preeclampsia. So, in addition to that, because we have decreased volume filtrate, we are going to have decreased urine output, and that will present as oliguria or even anuria, where we don't have production of urine. Oliguria is few production of urine. So we go to the other pathophysiology, which is said is extravasation of fluid from the intracellular space, and the first thing that is going to cause is edema and weight gain for the mother. And then we also have pulmonary vasoconstriction and pulmonary edema, and this is going to present as crackles and shortness of breath. In addition to that, in terms of the eye, it can also present as papilledema. And with that, we go to the other pathophysiology, that is the intravascular coagulation with progressive consumptive coagulopathy, and this is going to predispose the patient to have thrombocytopenia. This is because of the consumption of the thrombocytes. And lastly, also, in addition to that, because we said in preeclampsia, we're going to have placental perfusion and ischemia, and this is to the fetus. We are going to have intrauterine growth restriction, which is usually asymmetrical. We also have intrauterine fetal demise, oligohydramnios, that is small production of the hydramnios fluid, and the fetus will be predisposed to placental abruption. So I have another slide describing the pathophysiology of all of these. So this is the pathophysiology in terms of the fetus. We are going to have ischemia, that is the placental ischemia, meaning you are going to have reduced perfusion to the fetus. And when you have reduced perfusion to the fetus, you are going to have decreased decreased filtration of fetal blood, and as a result, we are going to have decreased urine excretion into the amniotic sac, and as a result, we are going to have oligohydramnios, which is measured in terms of ultrasound, that is AFRA of less than 5 centimeters, or deep pocket of less than 2 centimeters. So in addition to also have decreased perfusion, you also have going to have decreased or no adequate nutrients because there's decreased perfusion to the fetus, which will result to fetal growth restriction, which can result to intrauterine fetal demise. So in terms also of ischemia, which is going to produce toxin, you can also have placenta inflammation, and you also have increased resistance of blood flow to the placenta from the umbilical arteries, which will result to absent or reserved blood flow in the umbilical arteries, which will now be an indication when you measure through this in an ultrasound. This can be an indication for induction of delivery. So in addition to that, you're going to have fragile ischemia is going to cause us to have fragile vascular connection between the placenta and the uterus, and this is going to cause easier separation of the decidua basalis from the fetal vessel, which now will cause placental abruption. Placental abruption will present as vaginal bleeding and uterine pain. And in addition to that, you're going to have immediate fetal stress to the fetus, which will cause us to deliver.